Hi there and welcome. My name is Dr. Marlena Jabara, and I'm a board-certified musculoskeletal radiologist. I'm also the proud founder of Rad Pod Squad, dedicated to community, collaboration, and mastery of foot and ankle imaging interpretation. I'd like to give a special thanks to Dr. Rohr Peterson for presenting challenging cases from across the globe, and for Collective Minds Radiology for providing tools that we can discuss these wonderful cases in community and collaboration. So thank you. So let's go to the tape. So here we have a case of a 20-year-old athlete who sustains an injury and cannot walk to follow. When we first open up the case, we are confronted with these bone contusions, osteochondral contusions, and edema throughout the metatarsal neck. Notice the changes of the shape of the metatarsal head and the chondral loss along the side. This is an osteochondral contusion medially. We can see bone marrow edema along the metatarsal neck. We see joint congruency, and then we can take a look at the sesamoid complex and its positioning. When we look at sesamoids, we want the sesamoids to be on about the same line. When we see that there's retraction of one or another, we want to give that a measurement, as we can basically tell that if something's greater than 3 millimeters in distance of gap, that may indicate that there's actually a plantar plate rupture. So if you see that on x-ray, go ahead and recommend that MRI, as the patient might have a plantar plate tear. Moving in past the edema of the bony structures into the ligament and capsular anatomic changes that are occurring here, let's get oriented by seeing the sesamoids at the level of the intersesamoidal ligament. Medial sesamoid, lateral sesamoid, intersesamoidal ligament. We see the flexor hallucis tendon superficial to that, and of course the flexor hallucis brevis, both the medial and lateral. The sesamoid is invested not only by the flexor hallucis brevis, but the abductor hallucis actually comes to attach on a portion of the flexor hallucis brevis, and the abductor hallucis then will go on to attach to the proximal phalangeal base, providing capsular ligamentous support. What we can appreciate is the myotendinous grade 2 partial tear of the abductor hallucis muscle, and even the edema that it is extending towards the flexor hallucis brevis, which is intimate at this location. So we see those myotendon injuries along that muscular support. Looking at the lateral flexor hallucis brevis tendon, we see that's further reinforced by the conjoined tendon band of the transverse head of the adductor and the oblique head of the adductor hallucis muscle, further joining the flexor hallucis brevis, attaching then to the proximal phalangeal base. What we can see from the sesamoids to the proximal phalangeal base is that there's a fluid-filled gap, and we can appreciate the tear of the sesamoidal phalangeal ligament as it goes through that entire region of gap between the sesamoid and the proximal phalanx on the medial side. Moving to the lateral side, we can also appreciate the torn edges of the sesamoidal phalangeal ligament as the fluid traverses through the full thickness defect. Lastly, we can take a look at our sesamoidal metatarsal ligaments. Let's go to the medial side here. And we can see sprain of the sesamoidal metatarsal ligament, seen here, that there are still fibers there, but there is edema. And of course, moving to the lateral side, we can appreciate that they are intact, seen better on the transaxial images. So all in all, our findings so far, we have our sesamoidal phalangeal ligament tears, medial and lateral. We have a myotendon injury of the abductor hallucis and the flexor hallucis brevis. Now let's move into the collateral ligament complexes. Let's take it from the lateral side. From the sesamoid, not only do we have those muscular compartment changes and reinforcements, but we have the sesamoidal accessory ligament, and that you can see right here. And that's going to join our proper collateral ligament and perform and basically reinforce that lateral side of the capsule. Let's take a look at that coronally. So coronally, we can appreciate our collateral ligament proper, and we can see the accessory collateral ligament of the sesamoid. So the sesamoid accessory collateral ligament and the proper collateral ligament. We can see that there is edema dissecting through these layers, but they're not retracted. So I would call this a sprain. On the medial side, we can appreciate the medial tibial collateral ligament, the main collateral ligament, and this is our sesamoidal, accessory sesamoidal ligament, and we see that there's a gap between the tibial collateral ligament and the sesamoidal ligament, indicating a high-grade partial tear at the proximal attachment of the tibial collateral ligament, very close to this bone contusion. Furthermore, we can appreciate on this view, this is our abductor hallucis, and this is our adductor hallucis with its transverse and oblique heads. That's that looks like on coronal imaging. Of course, our sesamoids, intersesamoidal ligament, flexor hallucis tendons, and that myotendon strain seen here. I think you can appreciate the connection between the abductor hallucis and the flexor hallucis brevis through this amount of myotendon injury seen here, where this is that torn conjoined area that we looked at on the transaxial view. To complete the reading, let's look at the extensor hood, the extensor hallucis, the extensor digitorum brevis, normally attaching into the joint capsule and also to the proximal phalangeal base, all intact. We can see that the region of the transverse retinaculum moving to the sagittal band is intact with mild poor definition there, consistent with mild sprain, no laxity of the tendon. So this is a fantastic case. To wrap it all up and just to make sure we've hit all the images, and also what I didn't mention was the actual plate itself. So looking at the metatarsal, removing our metatarsal head, if we remove the metatarsal head and we look down deep into the complex, the region that lives in this location is your plantar plate proper. And on either side, you can see that the sesamoidal phalangeal ligaments are torn, and indeed what's in the middle of that, even though we're volume averaging on this slice with the flexor hallucis tendon, when you look at that under a transaxial view, after you see the flexor hallucis, you're looking at pieces of the actual plantar plate that are torn in this patient. So putting the sum total of all the findings together, we can appreciate that there are sesamoidal phalangeal ligament tears, both medial and lateral, a tear of the plantar plate itself. We have a partial tear of the tibial collateral ligament at its proximal attachment, seen here. The sprain of the lateral collateral ligament complex. We have intermetatarsal bursitis seen here. And thank you for the wonderful collaboration on this case. I hope that you have enjoyed this presentation of RadPod Squad. And if you have enjoyed this presentation of RadPod Squad, I encourage you to get involved.